Okay, so I guess we are connected. Gaurav, are we connected?
Sir,
Can you confirm?
जसप्रीत
अभी लिंक भेजा नहीं इन्होंने मेरे पास, बट आई गेस वी आर कनेक्टेड.
सर भेजा लिंक मेरे को, अभी अभी भेजा है, एक बार आप देखिए व्हाट्सएप पे सर.
हाँ आ गया. ओके, सो
यस सर.
right, so good evening everyone. We are going to discuss INICET questions. Recall, main purpose is to collect the question, and when we get a full question, we can give you the right answer. Today I'll try to cover as many questions as possible. So this was a straightforward question. Common, and if you have any query, you can write it down here. Commonest hernia in female is. You see, the commonest hernia in female is, of course, indirect inguinal hernia. Although femoral hernia is 4 to 5 times more common in female, and obturator hernia is called old lady hernia. This is also common in female. So both these hernia are common in female, but overall most common hernia is indirect inguinal hernia. So answer of this question is A. I don't think any confusion here. This also I discussed when I discussed hernia. This is very thoroughly covered in discussion also. Now this is another question where patient comes with dysphagia, halitosis, weight loss, and a bird beak sign image was given. Again, it's a straightforward question. Answer is achalasia cardia. Another question, that is rat tail sign, that you get in both achalasia and cancer. Although in cancer the rat tail will be irregular and achalasia it will be smooth. That also I discussed in regular back discussion. So now third, not done in primary survey, X-ray chest, NCCT, ICD and intubation. Now here I'd like to know from you, only one options were correct or multiple options were correct? Can you tell me one option or multiple option in this question? If only one option is correct, then of course answer will be CT scan. That's not done. So Yash says that here the age was 26. So of course it's a young age. So here also cancer is unlikely.
Multiple choices in
multiple. Then the
survey.
Answer will include NCCT and X-ray chest both.
Yes, sir.
X-ray is not the primary survey, it's adjunct. Primary survey only ABC, airway, breathing, circulation. ICD and intubation, they come under breathing, so that you have to do. So Gaurav, I think multiple means so A or B, both will,
yes, sir.
Will be. Yes,
so
sir,
no
yes, problem
sir.
Here.
Both now, chest X-ray and this thing.
Now another question in relation to ulcerative colitis, correct about Crohn's is, hematochezia is more common in UC. Less risk of cancer, no, colon cancer risk is more common in UC. Contiguous again UC. Perianal region you get in Crohn's disease. So answer is D. And in Crohn's, perianal means, in Crohn's you know what are the main differences. Crohn's can involve any part of GIT. 30% start from ileocecal area. Crohn's has skip lesion. Crohn's is transmural. Strictures and serositis more common in Crohn's, and anal canal involvement and fistula and more common in Crohn's. So these are the main feature in Crohn's rather than ulcerative. So here the answer is D. Hematochezia is not the main feature here. Rather abdominal pain, abscess, fever, all these are more common. So again, this is a straightforward question.
Chest tube, somebody, sir, they are asking, Roshan Jha asking, what about chest tube? Chest tube comes in primary survey only because when we do the breathing part and if the patient is having hemothorax or pneumothorax, we put the chest tube. So that is in primary survey only. Okay.
Chest tube, intubation, all these are part of breathing. Agar fistula tha, to perianal mein fistula in NO hi hota hai. So if fistula was there, that is a fistula in NO, perianal. And that was the answer. And recall, you have to tell me, I don't have the options. So my main purpose is to collect the options. So if fistula was the answer, fistula you get, because it's transmural. This is very simple. There's no need to get agitated. Crohn's is transmural ulcerative colitis confined to mucosa and submucosa only. So crypt abscess, mucositis, all this you get in ulcerative colitis. And fistula stricture you get in Crohn's because it's transmural. So whether it's fistula in NO or any GI fistula, but fistula is usually enteroenteric, either enterocutaneous, enteroenteric, jejunocolic fistula. Entrovesical, colovesical fistula you don't get in Crohn's, that you get in diverticulitis. Non-caseating granuloma also you get in Crohn's. Okay? Yes, colon cancer get less in Crohn's, more in ulcerative colitis. That's correct. UC risk is more in, cancer risk is more in ulcerative colitis for colon as compared to Crohn's. Any other confusion here? And ulcerative colitis risk for cancer is first 10 year 2%, next 10 year 8%, and next 10 year, first 20 year 8%, first 30 year 18%. That's another old MCQ. No, not equal risk of cancer. UC has more risk of cancer in colon as compared to Crohn's. Small intestine cancer risk is more in Crohn's, large intestine colon more in ulcerative colitis. So answer is D. The fistula is more common in ulcerative Crohn's, and anal canal is not involved in Crohn's. Not in UC, sorry. It's only involved in Crohn's. No, I don't understand why we don't waste time. I don't have time to waste here. I'm repeating, and this for the last time. The GI cancer is both in Crohn's and ulcerative colitis. But this option I've taken from today only, from your recall, one of the student recall.
See, this session is about the recall only. Okay, we are trying to get the options here. And once, like in 2-3 days, when we get the options correctly from the different sources, then there will be a formal, after knowing all the options correctly. I mean, we cannot know all the options, but like from the different sources, when we get the options, then there will be a different session. This is just a recall session. We are not here to discuss the topic and all. This is just a recall session to know that actually what were the options, and based on your feedback only, we put the options and we go for we try to figure out the option.
You
depending
see,
on what options
the wrong option. You tell me 4 options, then I'll tell you the answer. You have to tell me the option. I did not give the exam, so I do not know the option. I've only collected it, what you told me. Some of you told me. So like this, we are simply waste time. So either write 4 options and ask what is the right answer, or otherwise what we have collected, I can only discuss this. So anal canal is not a problem, then fistula. So Crohn's and ulcerative colitis differences are very, very basic and very, very simple. Crohn's being transmural causes more fistula, ulcerative colitis causes more mucositis and crypt abscess. These 3 are common in ulcerative colitis. There's no doubt about it. This is common in Crohn's. So you have to understand what kind of question was there. Why answer should be hematochezia? Hematochezia is more common in ulcerative colitis. Because you have written hematochezia doesn't mean it's the right answer. Hematochezia is more common in ulcerative colitis, not in Crohn's. Crohn's develop abscess, fistula, pain, obstruction, fever, toxemia. So what is right about Crohn's is Gluteus has given 4 options. I don't understand what's the problem here. Fistula, less risk of colon cancer, yes. Anal fistula, yes. Contiguous, no. Hematochezia, yes. If these are the 4 options, then Crohn's has a skip lesion. So basically, whatever question was there, there's confusion. We cannot tell you the answer unless we know the exact option. But I will repeat, you can make the answer, you can make out the answer by yourself. I'll just repeat and then I'll go to next question. I don't want to waste more time on this question. Crohn's can involve any part of GIT. Just forget the options. Listen what I'm saying. Crohn's, both are seen in young age. Crohn's can involve any part of GIT from oral cavity to anal canal. Aphthous ulcer are common. 1/3 cases starts from ileocecal area. Crohn's is transmural. Ulcerative colitis remains confined to mucosa and submucosa and only involve colon, rectum only, no anal canal. 15% cases only left colon, 35% cases, 50% half colon, 35% full colon. 10% cases, it can involve terminal ileum called backwash ileitis. So, ulcerative colitis is contiguous. Crohn's has a skip lesion. Bleeding per rectum is more common in ulcerative colitis, and fistula in NO and strictures are more common in Crohn's. So, these are the basic differences. Whatever options are given will be like this only. So, because I did not give the exam, I do not know what the options were. But these are the basic difference. Now, you can make the answer by yourself. Hoarseness of voice after surgery for papillary cancer. Yeah, seldom hematochezia is correct, Tamanna, because hematochezia is not very common here. But we have to see what other options are. So maybe here, if the hematochezia is rare, that's a feature of Crohn's. So basically, what options are there? You have to make the answer by yourself. Now, hoarseness of voice after surgery for papillary cancer could be due to all except. Now, you see the two nerve injuries in thyroid surgery. At the upper pole, external laryngeal nerve injury, and this leads to loss of timbre, loss of high-pitched voice. Lower pole recurrent laryngeal nerve injury, this leads to either hoarseness or dyspnea. If bilateral recurrent nerve injury is there and partial injury, it causes very severe dyspnea. So if, and see here, tubercle of Zucker candle is in the posterior part near the lower pole, and that is very close to recurrent laryngeal nerve injury. So this you can injure, tubercle you can injure. Beer's triangle is a triangle at the lower pole, like here, bounded by common carotid artery, inferior thyroid artery, and the nerve. Here also the nerve may get injured. So, Beer's triangle, the nerve can get injured, and this is the triangle we take care of. So, here we have to be cautious. And superior thyroid vessel ligation will lead to external laryngeal nerve injury. Normally, strap muscle surgery do not lead to nerve injury. So, I exactly do not know the exact question. If you can prevent it by, if the question is prevented by, then I would say Beer's triangle. This is the triangle where we have to take all precautions. So, if the question is prevented by, then it will be Beer's triangle. Beer's triangle is basically a triangle that defines the location of recurrent laryngeal nerve injury. Jaw's triangle is for upper pole and Beer's triangle is for lower pole. So if the question says it's prevented by, where you are cautious, then I would say Beer's triangle. And which step will not injure the nerve, then I'll say strap muscle. Some of you are saying it's the exact question, some are saying prevented by. You gave question exam paper only 3 hours back, still you are confused. If this is the same question, then the answer would be strap muscle. Normally in strap muscle dissection, you see how we do thyroidectomy. I'll just tell you the steps so that you understand. Basically, we make first the rose position, the rose neck extended position. Then we make incision, coccus incision, 2 centimeters above the sternal, upper sternal border. Then we raise the skin flap along with the platysma. The flap is raised with the platysma. Then you ligate the anterior jugular vein. This is the strap muscle. You separate the strap muscle. This is very, and this is the jaw retractor, which already have come in exam. So we separate the strap muscle like this, and the nerve is not injured here. Then you put the finger and make a plane between true and false capsule. And then the first vein you ligate is the middle thyroid vein. That's another old question. What is the first vessel ligated? Middle thyroid vein. Then you go to upper pole, then you go to lower pole. And the nerve, I told you already, the nerve which can get injured. Upper pole pe external laryngeal nerve, lower pole pe recurrent laryngeal nerve. And strap muscle normally will not cause any injury to nerve unless you cut the strap muscle very later. So if prevented that what is the area you are very focused or you take all precautions, then the answer will be Beer's triangle. Beer's triangle is for recurrent nerve. And if which is not causing injury, then the answer is strap muscle.
Yes, sir, it is clear then the same thing. If it is prevented by, then Beer's triangle. Otherwise, if it is, the question was not occurred during, then strap muscle.
All of them wrote the same exam. Why there's a confusion? Half of them saying prevented by, half saying.
Maybe some mix-up, sir. But we gave the concept that whatever was the question,
if this
the answer
question
was according.
says that which is the most common injuries, then answer is C-kit. If it says not seen injuries, the answer is NDR1. C-kit is the most common mutation. PDF alpha is second most common mutation. Succinyl dehydrogenase you do get in carnate diet. In carnate diet, just you can get this. So these three you may get, NDR1 you don't get. Most common will be C-kit. So what was the question? Most common or not seen?
So they are saying not seen, so NDR1
NDR1 is the answer then. NDR1. Not true about Wilms tumor. Presents with, if not seen was the question, then answer is NDR1. Not true about Wilms tumor. Presents with mass. This is the most common presentation. Survival more than 80%. That's true. Wilms tumor is chemo-radio-responsive and has a good survival. Male-female ratio is almost 1:1. 1.3:1, we consider 1:1. And seen within 6 years. So your usually mean age is 3.4 years for Wilms tumor, but usually seen within 1 year. And lung metastasis is early and the most common site. So D is the wrong statement. This is how you differentiate. There are 10 points to differentiate Wilms tumor from neuroblastoma. One of them is this only. Neuroblastoma goes to bone, Wilms tumor goes to lung. So is there any confusion in this question? And age is also less than 6 years. Well, in the previous question, NDR1 is the answer. There's no doubt. Yeah. So here, any confusion?
I guess it is clear, sir.
Okay. So this is okay. Now let's come to the next question. So I guess you had a question where there's a coffin-lid shaped crystal with alkaline urine pH 8.5. Can anyone write the options here? What was the option? What was the question actually? And undoubtedly, this is a phosphate stone, triple phosphate, oxalate. Oxalate is envelope shaped, coffin lid, phosphate, and cysteine hexagonal. So no problem in this question. No,
yes, sir,
uric
clear,
acid does not form in, oxalate. So uric acid and cysteine forms in acidic urine. Oxalate can form at any pH and phosphate forms in alkaline urine. This is a triple phosphate, no doubt. So I don't think there's any confusion here. Triple phosphate. Coffin lid. This is the coffin lid. This year, TND, I have this question that hexagonal crystal and acidic pH with dietary restriction we don't do. Calcium is not done. And during that question, I do show you this film where envelope shaped is oxalate, hexagonal cysteine, triple phosphate is this. So this question already we have covered this year in TND only. Another question was history of trauma, unequal pupil and CT image given. And what is the next step? So can anyone tell me other two options? Other two options, osmotic diuretic. Of course, answer is surgical evacuation. Immediately do a burr hole or evacuate the hematoma. But other two options?
GCS less than mention is also going in favor of surgery only.
Yes, GCS less than 10. So that was one part. And what were the other two options? Wait and watch. Okay, one option was wait and watch.
And anticoagulation is one more option they're saying.
And thrombolysis.
Thrombolysis, yes.
So thrombolysis, of course, will not do. This is a extradural EDH. So obviously answer is immediate evacuation. Extradural is a surgical emergency. Subdural is not emergency. You receive a patient in the night, you can wait till morning. Extradural, the rule is if the patient comes in night, he should be operated before sunrise. If he comes in the afternoon, he should be operated before sunset. So extradural is a emergency, okay? And subdural, like these two are extradural because they are biconvex. And this is subdural, which is concavo-convex, so like this. And chronic. Well, midline shift is not present. Usually, midline shift of more than 0.5 centimeter is an indication for surgery. It's very difficult to see midline in picture. You can only see it on different cuts of CT scan.
See, even if there is like midline shift was not there, suppose they have not mentioned, or the GCS is 10 they have given, unequal pupil is a telltale sign that the herniation has already started.
Yes.
And this is the time, if you don't operate, patient is hardly having like half an hour, 1 hour left. Okay, so if they have given unequal pupils, it means that herniation has already, I mean, it is putting pressure and this is the time you should operate.
Superior artery ligation, I don't understand, Rahil, what artery ligation will do here. Extradural pupil dilatation and third nerve palsy is a transtentorial herniation of uncus of temporal lobe, which is a definite indication for surgery. So immediate surgery, midline shift doesn't matter here, immediate surgery has to be done. So this is a chronic subdural concavo-convex, acute white, and this is chronic, which is black. Subdural. Subdural we can wait, but not extradural. Midline shift doesn't matter, there's a transtentorial herniation. Not a risk of cholangiocarcinoma. So this also I discussed in TND this year only. Opisthoarchis and Clonorchis sinensis, two worm can cause cancer. Caroli's disease is a risk factor. Primary sclerosing cholangitis and primary biliary cirrhosis both are risk factor. While hepatitis B is basically for hepatocellular cancer, it is a very low risk for cholangiocarcinoma and intrahepatic, but out of these four, this is the best answer. So, any confusion here? The answer is D.
I guess it is clear cut, sir. This should be hepatitis B only.
So no problem here. Well, another question was stab injury, X-ray given, and diagnosis asked. In X-ray, it was white with a lower border like this. So this, of course, is a hemothorax. For pneumothorax, no, if it is cholangiocarcinoma and the word is not intrahepatic, then of course it is hepatitis B. Hepatitis B can cause both HCC and cholangiocarcinoma, but hepatitis B can only cause intrahepatic cholangiocarcinoma, and that too the risk is very low. So out of these four, hepatitis B has the least risk, although it is a risk for cholangiocarcinoma, but out of these four, hepatitis B has the least risk. So that should be the right answer.
There is no confusion. Hepatitis B should be the answer.
The answer is hepatitis B.
No direct relation of hepatitis B. So Carollis also causes intrahepatic cholangiocarcinoma. Hepatitis B also causes intrahepatic. But as compared to Carollis, the risk is very less in hepatitis B. And in many case reports in the books also it is written that the direct association is not there. Okay, so there is no confusion. Hepatitis B should be the answer of that question.
Well, if the whole lung was white or half lung was white, there's a stab. Then there are only two possibilities, pneumothorax and hemothorax. Pneumothorax will be black. So this is a hemothorax. You can very well see the horizontal line. And this is again a hemothorax, and this is a pneumothorax. Pneumothorax will be totally black. Like here, this is a pneumothorax. No fluid level, that doesn't matter, bhai. It can be problem क्या आप लोग रट लेते हो, whether it is a half, whether it's full, whether it's हो सकता है खाली angle obliterated हो सकता है half हो सकता है full हो, they all are hemothorax. I'm not saying that I'm showing the same image it was asked. The diagnosis should be same.
The air fluid level is seen in hydropneumothorax.
See,
okay, if
this
there is
is
hydropneumothorax,
the air fluid level. I knew you will cause problems, so I've kept a hydropneumothorax picture also. This is the pneumothorax, this is the hydro part, and this is the air fluid level. This is called hydropneumothorax. In hemothorax, you don't have a horizontal line. You have a line going like this, plus there will be lung parenchymal shadow here. Compare this, where you can find some lung parenchyma, with this, which is pure pneumothorax. But anyway, it doesn't matter. Whether it's half or full, it is hemothorax.
Ashwini is asking why there is not diaphragmatic rupture, because if there is diaphragmatic rupture, usually the stomach goes and that will show air fluid level, because in the fundus part there is air fluid level. Okay, so that thing only explains that it is not a diaphragmatic rupture, because it was in the question it was written there was no air fluid level. It means it is hemothorax. Okay, it is hemothorax.
Contusion is not seen by stab, Divya. Contusion is by blunt injury. Stab will not cause contusion. Why you get confused on very basic points? Stab can only cause three things. Number one, pneumothorax. Number two, hemothorax. And number three, diaphragmatic injury. In diaphragmatic injury, you'll see bowel herniation, stomach herniation. In hemothorax, you get white lung. In pneumothorax, you get black lung.
Okay, so, given right side or left side doesn't matter. We are just trying to discuss the question.
This is the hemothorax. It can be half, it can be full. तो अगर white मिल रहा है तो ये, और स्टाफ से कंट्यूजन नहीं होता है, स्टाफ से हीमोथोरैक्स होगा. कंट्यूजन किससे होगा? ब्लंट इंजरी से. See another question. This is a pneumothorax. GERD atypical presentation. Can you tell me the answer was the multiple answers correct or only one or two answer correct? What was the question here? Multiple or only one option?
Multiple. I guess it was multiple correct.
Then
types,
all four you get. Laryngitis you get, vocal cord nodule and change voice you get, increased phlegm, that's more secretion, and water brash you get. Asthma you is precipitated and pulmonary fibrosis is precipitated. All four you get in atypical presentation.
Yes, all four.
The typical presentation are heartburn and water brash. Patient can have really dysphagia. Those are typical presentation. Atypical means laryngeal spillover. The acid goes into the trachea or into the mouth. So it can cause even dental caries and CSOM also. That's also atypical presentation. So all four option is the right answer. Okay. Now here, I will not show the image because many of you will write the image was different. Of course, it was different. The question was a image in the breast, of the breast with ulceration, and they did ask the stage. So in stage, yes, it can cause pulmonary fibrosis due to the infiltration in the lung. So in breast cancer,
okay, sir, they said that there was no image given in the breast cancer. I guess the question was only ulceration.
Okay.
Just tell me
So
whether the question was
is T4B
yes
or stage 3B. So
okay,
if it is
if there is only ulceration, then it is straightforward. This is skin involvement, and that comes in T4B.
nipple
I guess the option was
retraction does
T4B
not
only.
change the stage. Nipple retraction due to ligament of lactiferous duct involvement. So nipple retraction is not skin involvement. Ulcer is the skin involvement. Yes. So you must have had.
No, Ashwini, I guess the question was which of these things can be seen in GERD. Okay, maybe the word atypical was not written, but the associated with GERD, all the 4 options which sir has shown, that is seen. Okay, most of the people, they are saying this only, multiple correct type, and those 4 things are seen in GERD because those are the pulmonary complications of GERD. And aspiration is also
Skin
one
was
of the
not
things. Lung
mentioned. What do
abscess
you mean
can
by
also be
skin
seen.
was not mentioned? There was an ulcer in the skin, no? That was the question. Skin was not mentioned means what?
Ulcer occurs in skin only. Okay, even if it is not mentioned, I mean ulceration, it is skin only. It has to be skin.
Ulceration skin changes where? It has to be in the skin, na? Ulceration और कहाँ देख रहे हो breast में? So stage, no, not stage 4, stage 3B or T4B, that's the answer. Okay? Whatever option, multiple answers correct, then both are correct. Stage 4 is metastasis. Skin redness and inflammatory cancer could be stage 4D, but again it's stage 3B, the same, skin involvement.
See, if they want to ask you about inflammatory cancer, they will specifically mention that the erythema on the skin is involving more than 33% of the skin.
Yes, and they
or
write
more than
redness and erythema and everything like inflammation.
So if it was not mentioned, it is skin cancer. I mean, it is skin involvement, T4B.
If they are specifically saying ulcer, then there's no confusion. It is T4B. Okay? There's no confusion. If you have marked something else, that doesn't change the answer. Answer is T4B only. Now, this is a question where I'm a little confused. Was the question marker of neuroendocrine tumor? I think it must have been discussed by Dr. Sanjeev. So I think I can leave this question. Okay, image was not given, doesn't matter. It's T4B.
Yes, sir, I guess this was discussed in pathology. So
I think this already must have been discussed in pathology. So we can leave this. I'll leave this. I think this has been discussed in. Then I guess there was a photo of PEG tube. So I guess was there a देखो problem क्या है ना, you just see the comma is not there, full stop is not there, inverted bracket is not there. No, that is not the point. The point is if they're asking there's an ulcer on the skin or skin is not written, ulcerated, then it is T4B. There's no doubt about it, okay? Unless it is inflammatory breast cancer, which will become T4D.
Okay, PEG tube, the question, what was the options if you know, or it was just a spotter kind of thing?
Yes, of course, this was not the image, no doubt. But was there an image of gastrostomy tube?
Okay, this ER positive wala question, gluteus, we'll discuss in the end. Okay, but the questions which we have right now, we are discussing, and later on we'll ask you that if anything we have missed from the surgery point, then we'll discuss these things also, okay?
Okay, so this was a gastrostomy kit. So I will tell you what we do in percutaneous endoscopic gastrostomy so that you understand. You only have to see the tube and you can understand. This is the stomach. So first we pass a endoscope, and from here we illuminate the area. I can see the red area from the skin. Now what I'll do, because the stomach is inflated, I will pass a needle from here like a intracath, and I'll pass a wire through the needle. So you must have seen a wire there. Through the wire, I'll dilate the tract, and through this wire, I will pass a tube here and inflate the balloon. You can see the balloon here. This will keep this tube in situ, and this is stopper here, which I'll fix to the skin. So they must have seen the whole kit of percutaneous endoscopic gastrostomy. Yes, guide wire is used, Chaudhary Prabhu, because after putting a needle, we put a guide wire here, and on the guide wire, like I'll use blue color just to highlight your point, we use a guide wire here, and on the guide wire, we thread the tube. Or we have a inserter like a trocar. So with the help of trocar also, we can put the tube in. So we have a trocar kind of like we do cystostomy. That also is one of the techniques.
It is like Tom Shinde, it is like a Seldinger technique only. First you put the needle, then you put the guide wire, then you dilate the track, and then you put the actual tube. Okay, so ICD maybe we don't do like that. In ICD, we put the tube directly. Orogastric tube is your nasogastric tube, or orogastric, it is the same thing. We don't do the same Seldinger technique. So that is more in the favor that the question what was asked originally, it was a PEG tube only.
No, if it was a, you see, listen, Tom, listen. If the tube was like this, then this is a gastrostomy tube, like this. And if the tube was a pigtail with a guide wire, then that must be for liver abscess drainage. That's a separate thing. And so you have to be sure whether pigtail was shown to you or a tube with a balloon was shown to you.
And a pigtail, there is no balloon there, okay? And the tip will be like coiled. So in the original exam, I guess most of the students are saying it was a PEG tube.
So unless I see the image, I cannot answer, but I think it was a PEG tube. And I guess you have understood what a PEG tube, how it's inserted. Now, bulb नहीं होगा बच्चे, balloon होगा. Harsha, it must be balloon. Bulb नहीं होता है, balloon होता है. Now, one question was abdominal pain, depression, stone, weakness, etc. Can any of you, flattest tube, Shri, just a red rubber tube. ये red rubber की tube होती है इस तरह से, no balloon, nothing, having a hole here and some hole here. वो हम rectum में डालते हैं to deflate the colon and rectum, to take the gas out from the rectum and colon. Flattest tube आप एनएल कनाल से डालते हो, उसमें कोई इंटरवेंशन नहीं है, उसमें कोई गाइड वायर नहीं चाहिए, डायरेक्टली वी पुट ए फ्लैटेस्ट ट्यूब. ओके, वो अलग चीज हो, रेड रबर ट्यूब होती है वो. सो कैन एनीवन हाईलाइट द क्वेश्चन एंड टेल मी द ऑप्शंस हियर? व्हाट वर द ऑप्शंस? Serum calcium was low. Okay, what else? And PTH was high.
Calcium low, PTH high means it will be secondary hyperparathyroidism.
Secondary hyperparathyroidism. Not secondary, not primary. Low calcium, high PTH, and high phosphate is secondary hyperparathyroidism. Why there's a confusion? Some of you are writing serum calcium normal, phosphate low.
Even if calcium was normal, then also it should be secondary. In primary, see, primary, both PTH and calcium is high. In secondary, PTH is high. Calcium can be either low or
bone
normal.
pain, headache, muscle weakness. Calcium was low and high PTH. What is the disease? Was renal failure an option there? And if the creatinine was high, then it must be chronic renal failure causing secondary hyperparathyroidism. If secondary parathyroid was an option, that is the answer. Secondary not given. Low calcium, high parathyroid, high creatinine. That's the CRF causing secondary hyperparathyroid. What was the option? What were the four options?
What were the options? That is the main thing.
No renal option.
Okay, there was no secondary hyperparathyroidism, it is fine. But what were the other options? If you're saying there was no secondary, means you know that what are the other options. So tell us the other options.
Okay, one option was primary. What were the other three options? Can you tell me? Bone metastasis will cause hypercalcemia. So bone mets, of course, primary bone mets is out, that will cause hypercalcemia, thyroid bone disease, bone and metabolic disorder. Pheochromocytoma will not cause hyperparathyroid. Hypothyroid will not cause this. Out of these four, the best option is hyperparathyroidism. Because bone secondaries will not cause hypocalcemia, will not increase parathyroid. Kidney is not an option. Devi Sujan has given four options, the best four options. So best answer is parathyroid, okay? Parathyroid and hyperthyroidism, that's the best option out of these four. Adrenal and pheochromocytoma will not cause this. Bone disease will not cause hypocalcemia. They cause hypercalcemia. Bone secondaries, I mean to say, metastasis. One of you wrote bone secondaries. Bone metabolic disorder or bone secondaries? Can you be more precise? Bone osteodystrophy you can get. But bone secondaries, some of you wrote, and now you're saying bone metabolic disorders. So was it a bone secondaries or bone metabolic disorder? Some of you are saying bone calcium, serum calcium normal, some saying serum calcium low. Okay, I am a little confused what the options were. Let us understand the concept. No secondaries, okay? Serum calcium high, serum phosphate low, serum chloride high, and parathyroid high. This is primary hyperparathyroidism. If serum calcium is low and serum phosphate is high with high parathyroid, then this is secondary hyperparathyroidism. So in this case, primary was the option. That is not correct because even calcium was normal. Hypothyroidism will not cause this. Pheochromocytoma will not cause this. Bone metabolic disorder could be option due to chronic renal failure. So depending on the question what they have given, CRF causing bone dystrophies can lead to secondary hyperparathyroidism. And there
I guess, sir, that should be the answer. If the renal dystrophy or renal osteodystrophy was in the option, then that is pointing towards the secondary hyperparathyroidism.
Yes, exactly. So the exact answer is secondary hyperparathyroidism. If secondary is not option, then it should be renal bone osteodystrophy, and then the answer should be metabolic disorders of bone.
Yes, bone and metabolic disorder should be the answer in that question.
Episodic diaphoresis. Anyway, so we have to look for the options here. One question on CT scan, which will be covered by Dr. Sumer. Episodic hypertension and diaphoresis, that's a feature of pheochromocytoma. But parathyroid should not be high in pheochromocytoma. Ganpati, already we have discussed that question. Extra-usual manifestation. If headache, episodic hypertension and diaphoresis is given, then it should be pheochromocytoma. Those are the features of pheochromocytoma.
Pheochromocytoma, sir, I don't think that PTH
No, I
is
think we are a
having.
little confused about the option.
So there is just
the
a bit
students are not very
confusion.
clear. I'm sure pheochromocytoma is not the answer. Either the answer should be secondary hyperthyroidism or metabolic bone disorder due to CRS. That's the answer.
Yes.
Now, one question on CT scan, I'm not sure of the option, but this, of course, will be discussed by Dr. Sumer. IOC of gallstone is not true. For IOC, we have ultrasound. Water zero Hounsfield unit is absolutely correct. Pheocytoma is not the answer here. That must not be the answer.
Yes, Chitra, Pheo will not affect the calcium, not PTH. Okay, so don't worry. Pheo and PTH rays, that could be seen in Men's syndrome, but I don't think that question was about the Men's syndrome and also.
And in that, the calcium should be high. It should be high because in men we have primary hyperthyroidism.
It is primary hyper, so yes.
So because calcium is normal, so of course. X-ray used is correct. So this question will be discussed by Dr. Sumer. X-ray used is correct. We use X-ray. No, bone and metabolic disease will be the right answer if calcium is low or normal and parathyroid high and phosphate high. So this question I'll leave. There's one question on breast cancer ER prognosis. Can you tell me the question? Can anyone tell the question and the options? 4 options.
I guess the third question was breast cancer, the estrogen receptor is for diagnosis or for prognosis. I guess this was the question. So obviously it has to be prognosis.
Also, for treatment as well. So what are the 4 options here? Can anyone recall the options? Okay, surrogate molecular marker. What else? Diagnostic marker. Prognostic marker. And so only one option was correct? Only one option was correct or multiple options? Only one option, then best answer is prognosis. Best option is prognosis. Okay?
Yes, it should be prognosis.
It is used for prognosis and treatment as well, but prognosis is the best answer. Okay? One question on thyroid amyloid photo. One option was prediction. Gaurav, they are saying surrogate marker, predictive marker, prognosis marker.
Sir, prognosis should be the best answer, sir. Prognosis, no doubt.
Only one answer, then it is for we use for prognosis. What was the question of amyloid photothyroid?
Medullary parafollicular cells.
Okay, so that's okay. Done in pathos, I'll leave that. But in this NEET, I have made 25 questions. Probably last week or this week you'll get it. So this was a question I kept last week only in your NEET question discussion, where the amyloid stroma they show, and that's a medullary cancer thyroid. Parafollicular cell, of course. So this also has been covered, or can anyone tell me the options here? Allogenic transplant rejection. If amyloid stroma, then of course parafollicular. That's a very simple question. No photo, it doesn't matter. Amyloid is parafollicular. C cell, medullary cancer thyroid. But remember, image they do ask, huh? So image, you remember, in NEET, you may get a question on image also. Pink, extracellular. So if image was not asked, that doesn't mean it's not important. You have questions image based. So allogenic cell transplant, cell responsible. You had the question like this. Okay, so it was a PSM, so we'll not discuss this.
Any other question of like surgery, if you remember anything which we have left from the trauma, from the urology. Urology, I guess, two questions only, that coffin lid shape and Wilms tumor.
Wilms tumor.
From trauma and once there was there a question on triage, that which is the color of priority?
Was there a question on the color coding of triage? Red, yellow, green, black? So that was a Kaplan-Meier, so that doesn't matter. That's not for surgery. So what was the question of trauma?
Yes, they are saying, Shri Hari is saying there was a triage question.
Immediate priority is red. That was a very simple question. Immediate priority is red.
Life-threatening condition, red color. Was that the question? Yes.
Immediate priority. The question was immediate priority in triage. The answer is red color. So that's simple. That there's no need to discuss that.
Was there this question, blood transfusion in the male and the blood group is not known? So was the O positive, O negative were like separate option, or there was like a combination of option in that? Blood transfusion in the male, blood group is not known. What were the options? Okay, so if it was single option, then it is like in the classes also I tell that if it is male, they have specifically asked, it should be O positive. But suppose there was an option like O positive and O negative both, then the answer should be O positive and O negative both. But single thing, if you want to mark, O positive for males, O negative for females.
And remember, it's for male only. O positive for male. Otherwise, both. O positive.
Yes.
MBBS synapse, the question was anatomy. And I'm not sure, but what I read was the cut section was from the foramen of Winslow, showing part of Lewis spleen, etc. And foramen of Winslow, the level is T12. That was the question. So I'm not sure, but I think it was a question where.
Okay, so O positive and negative, then that should be the answer. O
that should be the answer.
Negative.
That should be the answer.
One question was tail of the spens in the breast, it is crossing anterior axillary fold or posterior. I guess if it was the question, although anatomy question, but answer should be anterior axillary fold. Okay, tail of the spens is the part of the breast which is piercing the deep fascia into the axilla, and that will cross the anterior axillary fold. Okay, then
ICD does not have a bulb. It is just a catheter with hole, some hole here, and inside the catheter you will find a pointed stellate, kind of a spear kind of thing, like this. And we simply insert it. I will show you. Let me check if I get. I will show you the ICD catheter so that you. I'm not sure whether it's in this file or not, but in case I'll get it, I'll show you. Just give me 1 second.
And there was one question on the salivary gland that after the surgery of the parotid, there is some question about the deviation of the mouth or the sensory loss in somewhere in the face. Was there a question? Okay, in the parotid surgery, there was some nerve injury kind of question.
Sensory loss in lower lip. Sensory loss in lower lip. Just mouth deviation also.
What was there? What was the question and the different options? Okay, paralysis of the lower lip. Where was the damage asked? Was that the question? And the options were like tail of the parotid, lower pole of the parotid. Okay, main trunk, cervical, temporal. What was the other last option?
Was mandibular option? What mandibular option? Mandibular branch of facial?
Cervical and temporal cannot be the answer. Cervical supplies on lower part platysma and all temporal goes higher up. It can be due to main trunk or if, what was the fourth option?
Okay, the options are parotid duct, facial nerve trunk, facial nerve cervical branch, and auriculotemporal nerve.
Then the answer should be, I guess, the main trunk. If these were the options,
no, but there
then
should
main
be
trunk
deviation
should be
with
the
the main
answer.
trunk. No, there should be deviation also with the main trunk. There's no deviation. So out of these four, then only cervical is the best answer, then I guess. Well, maybe cervical branch going up. There's no other possible option here.
Yes. If it was written that there is no deviation, then yes, cervical is the only option left.
Because with main trunk, there will be deviation of the angle of mouth.
Yes.
No deviation, then cervical.
Okay, any question from the vascular disorder like arterial disorder or venous? I mean, from the surgical point of view, not pathology. There was one question about interventional radiology method of the treatment of aneurysm. I guess Sumer sir will talk about that. That is coiling. That was the answer. Okay, any other from the vascular system, venous disorder, arterial disorder?
Priyanshu, that you say transaction was given at level 2, liver, stomach, spleen. Liver, stomach, spleen is not a pinpoint organ. They are huge organ. And I can have a section right from T8 till T12, all will have liver, stomach, and spleen. So unless we know precisely, like you will see C-left trunk or something to identify. Probably in that question, it was foramen of Winslow, though I'm not sure. If it was foramen of Winslow, then it was T12. Liver, spleen, and stomach are the huge organ. Multiple sections can be there to these organs. So I think there were not many questions. The questions were also not very. Parotid duct cannot be the answer. Parotid duct will not cause nerve sensation, loss of sensation in the angle of mouth. Most common hernia already we have discussed, femoral, indirect inguinal hernia. Aneurysm management, coiling. Main trunk will cause paralysis, CJ. There's no paralysis, so it should be cervical branch.
Yes, primary survey
primary
question
survey question we have discussed that. We don't do CT and X-ray. So I think that's it, Gaurav.
Yes, sir. Yes, sir.
चलो ठीक है फिर. So ठीक है भाई. All the best to all of you.
Okay, so we'll try to find out the proper options and maybe after 2-3 days we'll come up with the, as we know from the recall, the proper question and the proper options. We'll maybe make a proper the session of the discussion. Okay, this is just a recall session. That discussion session we'll have it later.
Okay.
Cardiac tamponade, was there a question on cardiac tamponade, Priyanshu?
नहीं, fusion पे था, cardiac fusion पे था, वो medicine question है, radiology question.
Okay.
So that was not a surgery question. Cardiac fusion पे शायद was a question. Okay, so I'm going to log out now.
Yeah, thank you very much and best of luck to all of you for the result and for the upcoming NEET exam also. Okay, thank you. God bless you all.
Thank you.